Welcome to the Latte Lounge podcast. Join me, your host, Katie Taylor, as we talk balancing hormones, busting myths, breaking taboos, boosting libidos, and bolstering confidence. This series is brought to you in partnership with the Latte Lounge Plus, the new online menopause clinic where you can get online appointments with an experienced menopause doctor, a personalised treatment plan to manage symptoms and prescriptions, if right for you, delivered to your door, all for just £45 a month, and that includes prescriptions too. So check out the show notes for more details on how to get your appointment booked in. In this episode, I'm excited to welcome back to the podcast Neurologist Professor Guy Leschziner. During my last conversation with Professor Leschziner, we looked at sleep issues during midlife and menopause. And today we'll be taking a deep dive into the female brain and the impact of our hormones, lifestyle, and environment on our brain health. I want to find out why so many of us midlife women often complain of developing symptoms such as brain fog, headaches, and migraines during this time of our lives. And stay tuned as we'll also be examining the latest research and evidence on how to protect our brain health and potentially reduce the risk of developing Alzheimer's and dementia in midlife, menopause, and beyond. Professor Guy Leschziner is a consultant neurologist and a professor of neurology and sleep medicine at King's College London. He's a published author with ongoing research interests in sleep disorders, including restless leg syndrome, and he's presented 2 series on the brain and sleep for BBC Radio, and you may also recognise him from The Secrets of Sleep on Channel 4. So, Professor Leschziner, welcome back. Now, today we're here to obviously talk about brain health. We have a lot of women in our Facebook group and in our wider community, myself included, who often complain during midlife and menopause about all sorts of troubling symptoms such as brain fog, headaches, migraines, and this sort of lack of concentration. And a lot of us start getting very concerned, doctors included, that this could be that we're perhaps developing something like early onset dementia, Alzheimer's, which is it's really quite frightening. So I just wanted to start by asking you, what do we know about the changes that happen to the female brain in particular during menopause? And how much of these changes are hormonal, perhaps just versus general aging?
Yeah, well, I think you've hit the nail on the head, really, which is that some of this is related to the fact that we're all getting older, and obviously the menopause is part and parcel of that. But we do know that lots of women complain of the symptoms at the time of the menopause or the perimenopause. Now, actually, what do we know about the effects of hormones on things like brain fog, for example? And the answer to that, unfortunately, is not very much. Brain fog in and of itself is a very poorly understood condition or a set of symptoms that has really come to the fore, not only because of menopause, but also in terms of long COVID. An awful lot of people with long COVID are complaining of very similar cognitive complaints to those which women with perimenopause complain of. And it's very, very poorly understood.
We hear again, as you said, about the long COVID issue, and that's one of the worries. From women we hear from, that they're thinking, is it to do with a recent illness? Is it COVID? Is it menopause? And we try so many different things. I mean, for me, I went back and forward to my doctor, and they would say, well, you're juggling too much. Perhaps you're depressed. Perhaps you need to work less. Maybe you're just not eating very well, and you're eating too much sugar or sort of fatty, carb food, and so try and lose weight. And maybe because you're so busy with kids and you're not sleeping that you just can't think straight. But I know from a personal point of view, and I'm not here to push HRT. This is about having an informed conversation. But I know that when I did start taking HRT, the brain fog and the clarity of thinking was lifted within a matter of weeks. So, I'd like to sort of ask you about that. So from a medical and again, a lifestyle point of view, what can women try as a sort of first thing to see if they can lift that brain fog and get back that clarity of thinking?
Yeah, so in my experience, this is not usually an issue of what you're eating. And I think that that's a sort of, rather easy thing for people to say in a consultation. But I think that this really does go beyond what you're eating. The kinds of people that I see in my clinic are individuals in whom the brain fog is very tied up with other symptoms. So particularly, as you said, with insomnia. And so the conversation that I often have with people is, well, look, we know that insomnia can cause changes in terms of your cognitive functioning. Let's try and treat that. But at the end of the day, there is a very substantial proportion of individuals in whom, even once the sleep has been improved, their brain fog continues. And then I think, it is a question of trying to whittle down the possibilities, usually by trying to treat what we know is there and seeing whether or not the brain fog resolves. And in some cases, as you said, that is a case of treating the perimenopausal symptoms and seeing whether or not the cognitive symptoms go away. Certainly, I see a very large number of women who do complain of that brain fog associated with perimenopause, and when they are treated with HRT, their cognitive function resolves.
Yeah, and for those that perhaps it doesn't help, or they just can't take it, perhaps they've, for medical or surgical reasons, they can't or they don't want to. I'm just wondering what else there is that they can do, and also when should we be perhaps more worried and concerned that it could be something, more like early onset dementia? What's that sort of process about getting, I guess, that diagnosis and help?
Yeah, I think the first thing that I would say is that it's very unusual for that really to be the first feature of dementia. So, dementia, the cognitive processes that occur in early stages of dementia are not just sort of difficulty thinking and not just a clarity of thought. In fact, people with dementia usually don't complain of cognitive dysfunction. What they complain of, or usually actually what their relatives complain of, is that they are losing their memory or that there are marked other behavioral changes. So it's a somewhat different clinical picture. If, there are issues with memory. So, for example, what I mean by that is somewhat different to brain fog. It's the loss of autobiographical memory, or, for example, getting lost in places that should be incredibly familiar, which is a little bit different to what most people with cognitive dysfunction describe. Most people with cognitive dysfunction describe mental fatiguing, or they describe occasional episodes of, for example, putting the socks in the fridge, for example, or things like that. It is a slightly different clinical picture. But if you are concerned that you may be exhibiting more marked cognitive impairment, then that's definitely the time to go down the medical route, to have a chat with your GP, to see if there are any strong features to suggest that this is something other than the cognitive dysfunction associated with perimenopause, and then get a referral to a neurologist or another cognitive expert.
Yeah, maybe you could sort of talk us through the evidence around whether menopause and midlife is actually a risk factor for Alzheimer's and dementia, or is it a hereditary disease? Because it is, something that so many of us worry about.
We know that dementia is multifactorial, so there is a strong influence of genetics. There's a strong influence of lifestyle. One of the biggest aspects of risk for cognitive dysfunction, so cognitive impairment associated with conditions like Alzheimer's or other forms of dementia, is disease of the vasculature, disease of the blood vessels. And this is influenced by things like smoking, like high cholesterol, like exercise. Certainly, estrogen appears to be protective for cardiovascular and cerebrovascular disease, which is perhaps one of the reasons why there is such a disparity in terms of things like ischemic heart disease, in terms of coronary heart disease, between younger men and women. And the lack of estrogen later on in life results in a little bit of catch up in terms of cardiovascular and cerebrovascular disease in women. So certainly estrogen may, to some extent, be a little bit protective of developing conditions like this, and there may be a little bit of a catch-up in the rates associated with menopause.
I mean, I guess obviously there's not enough conclusive evidence out there for treatment options yet that can help reduce our risk for developing, Alzheimer's and dementia. Or, I mean, what are you aware of in terms of what is available? I mean, for risk reduction and, to stop obviously people from worrying, basically.
So I think the first thing to say is obviously, to go on ongoing HRT because of concerns regarding risk of dementia is probably not appropriate. As everybody I'm sure knows, HRT is not a zero risk treatment. And certainly at the moment, I don't think any neurologist would suggest continuing on HRT long term in order to provide some protection from dementia or other forms of cognitive impairment. I think the key thing is that we know that there are certain protective factors that apply to everyone, not just women who are going through menopause. So regular exercise, making sure your blood pressure is well controlled, not smoking, not drinking too much, continuing to develop cognitive function, so taking up new skills, learning. These are all protective and should apply to everybody, not just women who are going through the menopause.
Mm-hmm. We've said this a number of times on our previous podcast episodes about that. In other words, just reducing risk factor for future health and well-being is vital for all areas of our health, whether, women are worried about breast cancer or heart disease or osteoporosis or brain health. The healthier life we can all live, then we're reducing these risk factors all the time. I want to take a few seconds to let you know about our new online menopause clinic, the Lassie Lounge Plus. Now, I know that getting appointments or HRT from your GP is really hard at the moment. And if you've been struggling with your menopause symptoms and you don't know where to turn, then our online menopause clinic is here to help. We've partnered with the experts at Stella to bring you this clinic, where you can get online appointments with an experienced menopause doctor, a personalised treatment plan to manage your symptoms, and prescriptions, if right for you, delivered to your door, all for £45 a month. And that includes prescriptions too. I honestly wish this service existed when I was looking for help with my symptoms, and we're hearing such great feedback from the women who are already using our online clinic. Find out more in the show notes of the podcast or drop me an email at hello@lattylounge.co.uk and I'll share all the details.
There was something that I wanted to touch upon which relates to our previous conversation, which is this issue of sleep and cognitive function. So we know that obviously poor quality sleep directly influences our cognitive abilities the day after, but there's an increasing body of evidence to suggest a link between sleep and long-term cognitive decline. Now, we don't have all the answers yet, but we know that it seems to be the case that people who sleep very little seem to have an increased risk of cognitive dysfunction later on in life. This does create significant anxieties for many people with insomnia, but there's something really important to say about insomnia, in that insomnia and sleep deprivation don't always equate. In fact, for the majority of individuals with insomnia, actually the amount of sleep that they're getting when it's recorded using, for example, brainwaves, is not hugely different from normal individuals. And so for the vast majority of individuals with insomnia, although they may well complain of cognitive decline, that is reversible. It's when their sleep is addressed, their cognitive function normalizes. It's really only a very small minority of individuals with insomnia who have very, very limited sleep. What I'm talking about, 4 or 5 hours sleep. And that even the majority of individuals who say that they are sleeping 4 or 5 hours have what we term a degree of sleep state misperception. So that although they are waking up repeatedly through the night, their brain tells them that they've been awake between those awakenings, whereas actually on the brainwaves, they've gone back to sleep again. So even if you think you're one of those individuals with insomnia who feels like they haven't slept at all in the night, actually for the majority of individuals, the actual number of minutes that they're spending in sleep is perhaps not that short.
Yeah, I mean, that's actually very reassuring, because I know that you can often lie awake thinking you've seen every minute of every hour on that alarm clock, and actually perhaps you haven't. And just knowing that in itself might be enough to give you some sort of reassurance.
It's not at all unusual for us to bring in individuals into the sleep lab. And, I always make it a point to ask people before I discuss their sleep study results, how much sleep do you think you got? And it's not at all infrequent for people to say, well, I really don't think I slept at all. Yet when we look at the analysis, we can see that actually they slept 6.5, 7, even 8 hours. Okay, they may well have had some awakenings overnight and the quality of their sleep might be not great, but actually they've had a very decent amount of sleep.
That's interesting, and I will be reporting that back to certain family members. Now, we've obviously talked about the more sort of scarier, elements of brain health, as in Alzheimer's and dementia. But there's another very debilitating symptom we hear a lot from women in midlife and through menopause, and that's not just headaches, but migraines. And these are often women who've never suffered, particularly with migraines. And again, that knock-on effect of sort of just not being able to function at work and at home can be really disruptive. So I just wondered whether you could sort of talk about migraines, why we might experience perhaps an increase in them during midlife and menopause, and what women can do for relief.
Yeah, so it's no doubt that migraine is under hormonal regulation. Women are much more likely across the board to suffer from migraine than men. And we see a very sizable proportion of women with migraine who say that their migraines get much worse at particular points in their menstrual cycle. So it seems that there is something important about what the female sex hormones are doing to brain functioning that seem to predispose to migraine. And actually, it's very common for women, particularly in their 30s and 40s, and around the time of menopause, to see either a significant deterioration in their migraines or actually to develop migraines for the first time. The precise way in which the sex hormones influence migraine is not fully elucidated, but it's very clear from talking to lots of women with migraine that exists. And in fact, the literature bears that out. So the question about what we do with migraine, well, to some extent, it depends on how severe your migraines are. If they're very intermittent, then there are some lifestyle factors that you can undertake to try and improve your migraine control. We know that people with migraine tend not to respond very well to any changes in their environment. So what I mean by that is, either too much sleep, too little sleep, too much stress, too little stress. Actually, sometimes the release of stress, for example, on a Saturday when you've been working hard throughout the week, can sometimes precipitate these migraines. Eating regularly, making sure that you're not dehydrated. Basically trying to maintain your body's environment in a stable format is going to be helpful to control your migraines. There are some treatments out there that are complementary therapies for which there is some evidence for in migraine. So things like magnesium supplements or a B vitamin called riboflavin. These can all, to some extent, help some individuals with severe migraines. And then there are standard treatments for migraines if they are coming on very frequently. So if they're still relatively intermittent, then certainly taking a standard painkiller as an abortive therapy and as a method to try and stop the migraine in its tracks So things like ibuprofen, things like aspirin, or even paracetamol, taken as soon as you feel the migraine coming on, because it's much easier to treat a migraine in the early stages rather than to wait until it's fully established. For some individuals who are having migraines, and we usually use a cut-off of about more than once a week, then we will start migraine preventative treatments. And there are a range of different drugs, some of which were originally designed as anti-epileptics or antidepressants or blood pressure medications, that can be enormously helpful in terms of reducing the frequency and the severity of the migraines. And if there is a very strong hormonal component to it, then sometimes a hormonal manipulation can help. So, for example, in individuals who only have very severe migraines in their premenstrual period, when they're still menstruating regularly, we will very occasionally actually use the oral contraceptive pill and run it through for 3 months at a time. So rather than having a period every month, these women will have a period once every 3 months, and will limit the impact of their migraines on their quality of life. Occasionally, we can use preventative migraine treatments during that premenstrual period in order to try and prevent those migraines kind of coming on within that limited window. And then, of course, for women who are perimenopausal, for some women, HRT can actually cause a dramatic improvement in their migraines. Occasionally, it can make things worse. So it is a case of trial and error to some extent.
Would you ever say that migraines are also perhaps a warning sign that actually, your lifestyle perhaps needs addressing, and there's no better time to do it than in midlife? Obviously, I don't want to make people feel guilty about it. Sometimes you just can't prevent them happening. But,
Yeah.
I just wondered whether it's a good time to actually address lifestyle when perhaps migraines first appear in midlife.
Yeah, well, absolutely. I mean, as I said, lifestyle factors are important, and it's worth just examining how you're leading your life in terms of your stress levels, in terms of your sleep, in terms of your exercise and other aspects of your day-to-day life, to see whether or not there's anything that might at least be contributing.
Yeah, I mean, it's an interesting one, that one, because I've suffered that myself, and you do try a lot of different things to relax it, and nothing seems to help, and yet I think it's very reassuring to hear that it is fairly common, and women shouldn't be overly concerned. But before I let you go, I just thought I'd ask you again, like we did in our first episode, around the sort of sleep area, whether you've got sort of any last words of advice or tips, on not just brain health, but all these things, whether it's headaches, you're worried about brain fog or restless legs. What should be the next sort of steps? Who should you see? Where should you go? What should you read? When should you be concerned?
Yeah, so the first thing is really to make sure that there's nothing that you're doing in your lifestyle that might be impacting. Because many of the things that we've already discussed: exercise, sleep, stress. Some of those we can do something relatively easy about. Other aspects are a little bit more difficult to address. If you've addressed those, or you've not found any of those factors within your life, then I think the first port of call really is your GP. And what a lot of people say is that the engagement they get from their GP is variable. So there are some really excellent GPs out there. There are also some GPs that are rather overwhelmed, that have very limited time. So really going in armed with a bit of information to back up what you're saying, I think may be very, very helpful in some cases to try and address those sleep issues that you've identified, or whether you're having other aspects of perimenopause that might benefit from HRT, so that at least you can have a discussion with your GP about the merits of treatment of the perimenopausal symptom. Many practices now have a women's health or an HRT lead. These are GPs who are particularly interested in this aspect of medicine. And it's worth just exploring whether or not your practice has somebody like that, because the more informed, the more experienced your GP is, the more likely you are to get resolution to your symptoms.
Yeah, and that's a really helpful place to end. We always say to women who are struggling with a whole variety of symptoms that we have a symptom checklist on our website, which, well, it did used to have 34 symptoms, but it keeps growing the more we hear from women. So I just suggest you print that off, and we have a really good article on our website about how to prepare for a doctor's appointment. And as you've alluded to, if you go in there prepared, and you've read up and informed and listened to this podcast as well, they'll be grateful, because you're actually helping them with their, I guess, detective abilities as to figure out what's going on. Look, thank you so much again, Professor Leschziner, for coming back on our podcast. And we will leave all your contact details in the show notes at the end if anybody would like to know more. So I hope everyone found that helpful. And thanks again.
My pleasure.
This podcast is brought to you in partnership with the Lassie Lounge Plus, the online menopause clinic. With thanks to our podcast producer, Emily Crosby Media.